We can do that, ma'am. Yes, ma'am.
Hi, Dr. Dipanjali, Dr. Ekta. I think we can have a brief introduction from where you belong, where are you practicing right now?
Hello, ma'am. Myself, Dr.
Hi.
Deepanjali. I was Shivam's immediate senior in
Okay,
the
okay. Yeah, last time he introduced.
PGs.
Yeah, yes, yes,
Yeah,
yes.
yeah, yeah. So now he is my senior. Okay.
Teacher. Yeah,
So
you
it's
were
like
his
that.
teacher. Now he's your teacher. Yeah.
Yeah, yeah. It's
Role
a
reversal.
role reversal. Yeah.
Yeah, welcome, ma'am.
Last class was really nice. I
Yeah.
enjoyed a lot and learned a lot. So
Okay. Where
hope
are you
today's
these days?
class will be like that. I am currently in Calcutta, doing
Okay.
my glaucoma fellowship.
Okay, great.
Um, yeah, so let's do it.
Yes.
Okay.
Hi, Dr. Ekta.
Hello, ma'am.
Hi. Oh, good to see your face.
Hi.
Yeah.
Yeah, I am Dr. Ekta. I am currently practicing in Kanpur,
Okay.
Uttar
So
Pradesh.
you're nearby. Yeah.
Yeah, nearby. Yeah, and I have completed my glaucoma fellowship in 2021 from Arvind Eye Hospital.
Okay, that's nice.
Yeah,
Yeah.
so
So you also know
that
Dr. Shivam?
no, I don't know.
Okay.
Yeah, so basically during the tenure, we were actually my fellowship unfortunately was during the COVID time. So,
Oh,
so at that time, MIGS was like kind of evolving.
just revolving
Everybody
there.
was just doing. So we never actually got to do anything hands
Yeah,
on and
plus
all.
COVID might have affected the
Plus,
training
COVID has
also.
affected, yeah, a lot of things. So currently,
Yeah.
I am, yeah. So after completing the fellowship, I have joined here only in Kanpur,
Okay.
and I'm almost seeing. I'm seeing majority of the my OPD consists of majority of glaucoma
Glaucoma.
cases.
Chalo,
Yeah,
great.
yeah,
Yeah.
yeah,
Looking forward to meet you.
yeah. Same here.
Yeah. Okay. Right.
Nice
Okay.
meeting you, ma'am. Yeah,
Same here.
yeah.
Hi, Dr. Shalinder. Hello. Dr. Smriti.
Hello, ma'am. I'm Dr. Smriti Rabas. I'm from Hyderabad. I'm working as a glaucoma consultant. I completed my fellowship in 23, but I
Okay.
don't have any experience on MIGS, so that's why I wanted to do this
No,
course.
that's wonderful. That's wonderful. So you're currently practicing in Hyderabad only.
Yes, ma'am. I'm currently on maternity leave, actually, but
Okay.
otherwise, I'm practicing.
Congratulations.
Thank you.
Yes, hello. Looking forward to meet you.
Yes,
So
ma'am.
you'll be traveling all the way from Hyderabad,
No,
right?
I'm in Delhi with my
Oh,
parents, so
okay,
that's
okay.
nearby only, so it's
So
okay.
you'll be traveling by road?
Yes, ma'am.
Okay, because the flights are affected that day, 24th.
Yes, ma'am. I'll be traveling by road.
Yeah. Chalo.
Hmm.
See you soon.
See you, ma'am.
Yeah. Okay.
Good evening, Doctor Sir. Hello,
Good
Doctor Sir.
evening, everyone.
Good evening, sir.
Good evening. How are you?
Yeah, I'm fine, sir. Dr. Shivam, you can briefly introduce, sir.
Yeah, I will start in another 3 minutes, ma'am. I think so few people are more joining.
Okay, okay, right.
Till then, we can introduce Dr. Shailendra sir. We met, right?
We met last time, yeah. And
Yeah.
he's my batchmate, so it's okay.
Anybody else we have not met?
Okay, I'll give my brief introduction if you can
Yeah,
hear me.
please. Yeah, please.
Uh, yeah, my name is Dr. Shailendra Minhas, and uh, both of us, Amardeep and me, we are MBBS batchmates. I did my MS from Dr. Rajendra Prasad Government Medical College, Kangra, Tanda, Kangra, and then I did my fellowship from Mahatma Eye Institute, Nagpur in FECO. And presently, I am working as a senior ophthalmologist in Zonal Hospital, Dharamshala. I'm in Himachal Pradesh Health Services.
Even I didn't know that you learned from this Mahatma International this institute.
Mahatma Institute and
Y-
Eye Bank. It's in
Yeah.
Nagpur.
I think they have one branch in Bombay also.
Maybe.
Yeah,
I'm
because
not
when I
sure.
was in Bombay, so I just saw that name on the list of eye hospitals.
Yeah.
Looking forward to meet you.
Soon.
Ajay will be here.
Okay.
Yeah, so we are going to have a nice get together.
Sure.
Yeah. Thank you. Dr. Akshaydeep.
Um, Hello, good evening, ma'am.
Hi, good evening.
Ma'am, I'm Dr. Akshadeep Jain. I have completed my MS from Meerut, and I did my fellowship in cataract and IOL from Sadhguru Netra Chikitsalayah. So currently, I am working as a consultant in the secondary center, which is situated in Bareilly.
Okay, I think you know Dr. Kusum also.
Yes, ma'am.
She yesterday mentioned you, yeah.
Yes, ma'am.
She is my 1 year senior, and fortunately, we were both in Navy for some time.
Okay, ma'am.
Chalo. We'll see you soon.
Thank you.
Hello, Dr. Vijay sir.
Hello, sir. Meeting has been started, sir.
No, sir, we are waiting for you only, sir.
Okay. So nice of you.
I'm really sorry, sir, to disturbing. I think so. You had your OPRs, right, sir?
Hey, sir, actually, I am out of station for training, na?
Yes, sir. Yes, sir.
Okay, sir. Go ahead, sir.
Hello, Dr. Ashish, sir. Ashish, sir, can you hear us? Okay, sir. Thank you, sir. Dr. Ashish, sir is here.
I think sir's
Hello.
time is very precious.
So, hello, sir, can you hear us? Dr. Devendra, sir, can you hear us?
Yeah. I can hear you.
Oh, sir has put his background also. Thank you, sir, for putting the background. So, thank you, sir, for once again giving in very short notice. Sir has accepted. So, I'll just start with a brief introduction of sir. First of all, sir is my teacher, my guru, whatever I am and whatever I know, little bit about, like whatever glaucoma I know. I shouldn't say little bit because sir has taught me. I can't say little bit. So, whatever glaucoma skills and whatever I am today and whatever publications, whatever maybe my mix skills, whatever is all because of sir's hand. And sir is not just me, and he is one of the pioneer of mix surgeons in. He was one of the first persons doing mix in India, and he has popularized more than 10 types of mix he's doing. And if you look at his OT list, he has like every week three, like 30 to 40 mix and different kind of mix which he is doing, and he's inventing and developing newer kinds of mix. So it's very great, really great to have sir amongst us, coming to and meeting us in next week. And it will be really great for and from on behalf of all the wet lab participants, I really thank you, sir, for just taking out your time to just brief us about what MIGS is and your practices of MIGS and the newer MIGS, the initial MIGS with like the Bang and the Tanito. And one thing about sir was the first person to bring Tanito in India, and ours was the first paper to be published about Tanito in the world's most renowned journal of it. So, starting with sir's brief introduction, he's an associate professor and senior consultant at Arvind Eye Hospital, Tirunelveli. He was a long-term fellowship at Arvind Eye Hospital, Tirunelveli, and he has continued has he's also has a glaucoma fellowship in Bascom Palmer Eye Institute, Miami, in USA, and he has observership at various universities like Kellogg Eye Institute, Ann Arbor, Wilmer Eye Institute, John Hopkins University, Baltimore, and the New York Eye and Infirmary Mount. And he's the speaker of multiple international, and he's a guest faculties in almost all the conferences in India and abroad. He has more than 70 publications and presently associated number of national and international studies and research work, which is ongoing. He has multiple orations in his name and Best Glaucoma Paper Award for GSI, TNOA, and different conferences. He's a members of different society like AIS, TNOA, GSI, DOS, MPSOS, UPSOS, and he's a reviewer of multiple journals like BGO, JOJ, IJO, I plus one, I Vision Ophthalmology, and many more. And he has won many awards, like won WGC Award and Harvard Travel Grant Award. And not just about him, he has won multiple travel grants award. He has also inspired his fellows and juniors to get those travel grants. And thanks to him, also I also got the opportunity to win the APO travel grant. Thanks to sir. So I'll stop sharing and I'll invite sir to share his slide and discuss about the initial mix practices we should do. Thank you, sir. Over to you, sir.
Thank you so for kind introduction. And really, I'm not the first time one who did MIGS. A lot of other people started, but though I did a lot, started a lot actually. So can you see? Can you stop your share screen? Then I can share. Stop your screen share.
Yes, sir. I have stopped, sir.
Sharing is not turned on actually, so you have to allow me to share.
Yeah, Dr. J, can you allow sir to share screen?
Yes, sir. You can try now.
Yeah. Yes. Now I'm able to. Yes. Can you able to see my slides?
Yes, sir.
Okay. Can you able to see my first slide?
Yes, sir.
Okay. So, good evening, everyone. So today I'm just giving you the brief introduction about the Tanito and Tanito microhook. So before starting the MIGS, just have a little bit idea about what the mix, how it works, what the kind of mix actually, where the mix placed in our practice. There's a traditional practice once we taught in our previous days. Start with the medical therapy first, then do the lasers, and then if it fails, then come to the filtering surgery. So somehow MIGS is going to fill this bigger gap. So what we are doing practice, instead of directly taking all these patients into the filtering surgery or the glaucoma drainage devices, you can start the MIGS. Because why we need MIGS? Because MIGS have the very good safety profile, good IP control, and minimal trauma to the eye. So look for this is the trend, global trend of the microinvasive glaucoma surgery. So this is estimated in 2029. So the mix almost increasing. All the market have the put lot of resources, lot of R&D money has been put for the mix because it is showing the very, very good outcome. So when we come just coming to the mix, how the mix started. So mix actually in goniotomy is done in long back in 1936. Barkan did it, and it's quite popular for the congenital periodic glaucomas. But problem with this goniotomy, when we cut it, the leaflet will be closed after some time. So this is called the incisional goniotomy. Usually we do with the knife. So that's why in recent time we are doing the axial goniotomy. So axial goniotomy we are doing with the KDB, either Tanito, or using the simple needle bang that we will discuss is. So why it has become more popular or more effective? Because here elevate the TM and excise the some part of the TM and reach the multiple collector channel to the Schlemm's canal. That's why the neogoniotomy they become a more effective. So the multiple studies have shown the goniotomy, you whatever the way you do, it is going to reduce your IOP. So these are the device based where the MIG is going to work. One is a TM based, then subconjunctival space, supracoital space, and decrease aqueous production. So TM based MIGs are the device based or non-device based. Device based eye stent, trabeculotomy, KDB, Hydrus, those recently launched in India. Coming to non-device space is the GAT, microlot, or the PENG. Then subconjunctival gel stent or micro stent. Then supracoidal, really we don't have any device in the market. CyPass come into the market, but it's withdrawn from the market due to endothelial complications. And iStent Supra is still in the pipeline. They're not in the market. Then some people consider it a MIGS, but some people don't consider it a MIGS when you decrease the aqueous production by doing the ECP or HIFU. So it's debatable, but I strongly believe anything when you're treating with conjunctiva, opening the conjunctiva, cutting the conjunctiva should not be considered as MIGS. So there is some of the any MIGS how is going to work. Either we are stenting or cutting the TM, or we are dilating the Schlemm's canal. So in Indian scenario, if you go for the US right now, so many systems are there. They are working on the dilating of the Schlemm's canal and injecting the visco delivery. So these multiple new systems are there. Just for namesake, Omni, Sion, these are the some Veo, Tap 60 degree. They are the new dilatation system, though probably this may popular, may not popular in the future. So, but in the country like India, cost is the biggest factor. If you look for this device-based eye stent, is costing the 95 to the 1.5 lakhs. And when you compare with the KDB, again we have to pay around the 28, 29, and sometimes previously was 30,000. Now price reduced to 30,000 per blade. And company recommend the single use. Is very difficult for in Indian scenario use the blade for single time. So then coming to the GAT, bang and lot, really we hardly need any cost experts for the instrument. It's just technique, and we need the few cents money. So why Tanito micro hook we should use? So Tanito micro hook is a simple instrument. I come on later on. So in which what we do with the hook, we just clip the trabecular meshwork and the inner wall of the Schlemm's canal under visualization of the angle and reduce the resistance of the equal flow. Who are the ideal candidate for MIGS? Mild to moderate open angle glaucoma, glaucoma associated with having the cataract, and the patient who don't come for follow-up, or patient who are early glaucoma. So this is the initial indications for MIGS. Now slowly when the MIGS become popular down to 4 to 5 years, MIGS has extend the indications. So right now we can perform mild glaucoma, moderate glaucoma, and certain MIGS like GAT we can do in the advanced glaucoma also, showing the good result. Coming to contraindication, ocular inflammation, neovascular glaucoma, aphakic glaucoma, and advanced glaucoma once upon supposed to be the contraindication, but recent trend has shown the MIGS effective in advanced glaucoma also. So these are the, I'm sorry, I'm missing something. Yeah, so so these are the hook. These hooks are there. These are 3 hook: right hand side, left hand side, and straight hook. So you can see here these are the hook: right angle, left angle, and the straight one. So these hook is, you can compare how thickness of the hook is there. So first you can see the eye stent, this eye stent handle, and this is a trabeculotomy, and this is a cohocdural blade, and the Tanito micro hook. And you look how we hold all these things. So you can see this Tanito micro hook is similar to kind of Shinsky hooks. what we use in our routine cataract practice, and somehow we have the muscle memory. So the instrument, when we use to very frequently, we can do it very well, we can manipulate, and we can use it very in a friendly manner. So if you look for the extent of goniotomy we can do, so look, if you do any procedure like that, like abaxtant or trabeculotomy, when we use the hemstrocolotome, we hardly can reach to the 90-degree angle. While we perform with the trabeculotomy, we can reach 1/4 circumstances. While we do the GAT, we can do the 360-degree. Apart from this suture GAT 360, Tanito is the only instrument by which you can do around 180 to 240-degree goniotomy. So these are showed you the differences. So this is in this video I am showing after performing the phacoemulsification. Use the high density viscoelastic. We use Orogel Plus. You can use whatever the sodium 100 or Halon GB is available. Dock the lens. First of all, make your hair is the thing. Make the AC very deep and tight. And this is the instrument. Just I am cleaving the trabecular meshwork. Then other hand side of the left hand side of the instrument I took and doing the supranasal area. You can see right now this bony white area. This is the Slem's canal. Next slide. So this is the sometime really doing the cataract and glaucoma coexisting with the ocular coloboma cases. So doing the trap in such cases really a nightmare. So what we did, we just performed the phacoemulsification with the help of the with the iris hooks. And really in doing such cases, the glaucoma surgery, especially the trabeculectomy, even the putting the tube really is a nightmare. So just perform the first phacoemulsification, fix the lens, remove the iris hook, again use the high density viscoelastic and take the micro hook, throw the micro hook, just be entering the Slem's canal and cleaving the trabecular meshwork. You can see this back wall of the Slem's canal. And this instrument is very handy, no need to push hard, you have to gently go and make your anterior chamber tight at the end of the surgery. So this again in this video I am showing this doing the micro even in the PSEG cases. So first finish the phaco. So after the phacoemulsification, in such case I advise just hydrate your tunnel so your tunnel will not be leaky. You can get the anterior chamber tight with help of the high density viscoelastic. And here sometimes we are not efficacious, but sometimes we are not able to understand the TM structure because of the synechia. So with the help of spatula, I am doing the goniosynecholysis. Once we do the goniosynecholysis, inject the high density viscoelastic, you can see the underlying trabecular meshwork. Once trabecular meshwork is visible, then again here I think that Dr. Prasanna must have told you last class, when you entering into the instrument into the eye, go to the low magnification. When you're performing surgery, go into the high magnification. Here no need to just finish it so early, take your time because we are working in a PCG cases. Focus on the structure, try to understand the structure. It's not the pigmentation, it's a true TM only. Then once you understand the structure, then just we have to cleave it. And at the end, just make your AC tight. In PSEG cases, there is a risk of bleeding, so you can leave some amount of the viscoelastic at the end of the procedure. I'm sorry, my slides jumping a little bit. Yeah. So this is the first study. There's a lot of literature published in the US and Japanese literature, Japan by Masaki Tanito only. But this is the first randomized controlled study we published in the ophthalmology or glaucoma. So in this study, what we did, we have the prospective randomized control trial. Group 1 has the phaco, group 2 has the phaco plus goniotomy by Tanito microhook. This is 57 patients in each group. At the end of 12 months, phaco group IP reduced from 26 to 12. Phaco Tanito group, means our goniotomy group, 26 to 12.5 mmg, while phaco group 25 to 20 mmg. Look at the medication at the end of the 12 month in phaco Tanito group is only 0.2% of the 0.6 to the 0.2 0.2% patient needed the medication, while in FACO group 1.42 reduced to the 1.1 only. So there is a no major complication, no safety profile except the few hypema. So this is the much safer procedure. And similarly, we reviewed patient for the 2 year, and it shows the good IP control till the 2 years. So these are the other various study where published in literature, and it is showing the good outcome, having the comparable outcome what we are having, and the long term follow up to 3 years it showed the good control of IP. And this is another study where they compared the abdominal trabeculotomy by using the two type of hook, and they find one they use the KDB, second they use the Tanito micro hook. They find out either you do Tanito or FACO goniotomy, means FACO Tanito group, or either FACO KDB. The results are almost similar. Then another one more study here. In this study, they compared the Tanito micro hook with the eye stent, and we find out in the Tanito micro hook have shown the good IP control in compared to the eye stent. This another study is inferiority trial where they compared with the micro hook with the trabeculotomy, and it also shows micro lot is non-inferior to the trabeculotomy. So this various multiple literature are available with showing the efficacy of the micro Tanito hook. There is a complication. Most of the MIGs have the complication like the IOP spikes and hypema. Hypema though is not very macro hypemas. Hardly we get the micro hypemas. Usually they resolve within 3 to 5 days. So I am fortunate to meet Dr. Saki Tanito, who developed the hook. So now problem is this Tanito micro hook is not available so widely in India, especially right now. The one more company is Zozo Surgicals is making this hook. Actually, they are quite similar to the Tanito, but not exactly to the Tanito. So now coming to the band needle assisted goniectomy is called BANG. BANG, why we forced to come to band? Because again we need the sum of the substitute for the KDB, because KDB blade is costing the 30,000, and similar kind of action, similar kind of work can be done by using the either 25 gauge or 26 gauge needle to excise that tubercular mesh work. So that we talk about. So KDB is costing around the 30,000, and here band needle is just costing the few cents only. And look for this here, this needle, it doesn't require we don't require for bank, doesn't require any sophisticated instrument. This I am showing the Swan Jacob costing the 65,000, but right now lot of other lenses are available, Catina, iPrism, they hardly cost you 5.5 thousand to 6,000 rupees, and you can easily perform it. And doing this procedure have the short learning curve. So in this video, I am showing how to bend the needle. Either you take 25 gauge or 26 gauge needle. Again, I am reverting it. See, take the needle, just tip we have to bend, and bend at the 90 degree. And after the similar procedure, just go into the TM, and you have to excise the TM. While excising TM, no need to hurry, no need to single shot you can finish. You can take your time. Sometimes we have to do multiple entries when we are learning cases. Once you learn, then you can go single shot and do the goniotomy. So this is another video. Here I am showing this is a 26 gauge needle, bending the tip at 90 degree. Put the high density viscoelastic stick, and this is a Catina handled lens. You can see, you can have the nice exposure with these lenses also. You can see the lip also. This is a good part, so you can easily enter by seeing it, and just you cutting and removing the tubercle meshwork. Sometimes some places you leave the some tag, so you have to do the multiple incision you have to make. So you can see here again, here you can see that the back ball of the limbs is exposed, and you can take the forceps sometime to remove the tags, because once tags are there, they are going to fuse, and long term your result will be IP may be the high. So these are the some not much literature we have around the bang, but the few studies have shown they are showing the good outcome of the bang. So looking for the limited goniotomy, there's an old concept when you have limited goniotomy, you have the limited efficacy. Really this concept is changing because recent publication we are saying the outcome of the hemi-GAT versus GAT. So if you're treating the 180 degree or 120 degree in compared to 360 degree, IOP drop is almost comparable. So just to summarize a few points, when you do either GAT or bang, optimal microscope and patient positioning is very essential. Probably Prasanna yesterday talked about 30 to 35 degree head should be away from you, microscope should be turned around you 30 to 35 degree. Assess the proper Lindbergh before starting surgery is very crucial. Understand the structure because every angle is entirely different, not the same angle we see. We see the multiple angles and you understand the structure very well. And throughout the procedure, use the high density viscoelastic to keep the anterior chamber tight. Avoid trauma to the adjacent tissue. And always educate patient regarding the complication like the hyphema. Sometime it may happen, nothing to worry about it. So just to conclude, Tanito, MIGS-BANG is efficacious, safe in mild to moderate open glaucoma, and most importantly, they both procedures are the cost effective. It significantly reduces the IOP and provides the good visual acuity in early postoperative period. It may be the viable MIGS option, or not only viable, but they will be the earliest MIGS which we should be adapt when we become a MIGS surgeon. Thank you for listening.
Thank you so much, sir. You made it look so easy. I'm sure it's not that easy, the bang and Tanito micro hook.
It need practice. Actually, it definitely need practice. Once you have the practice, it's easy only. It's not that tough. Just we have to try to understand the structures, focus properly is going to be easy. It's not that hard. Any person who can do the good phaco can perform the MIGS.
So which needle do you prefer? It's 26 gauge or 25 gauge?
So most of the places the 25 gauge needle is not available. So you can easily reach out with the 26 gauge needle also. It works beautifully.
The standard one that we use for X's.
Yes, but if you use the 25 gauge, you have the little bit bigger bit, and it is recommended. But 25 gauge is not available everywhere. So 26 gauge work well.
I think we are open for questions.
Dr. Mayank Pangti sir has joined, sir. Can you, sir, I think so you missed many slides, sir. Any doubts, sir?
I just saw the bang part, the last two videos. Maybe I'll see them in the conference, rest of them.
Okay, sir. Any other doubts from the group is open for discussion. Can we start having discussion, please? Dr. Ekta, ma'am, any doubts, ma'am? Any question you want to ask?
Yeah. Hello, sir. Good evening.
Hi, good evening.
Thank you for the wonderful presentation, sir. Of course, you definitely made it look very easy, but still, a lot of practice is required. So I just wanted to know how do we assure the correct amount of pressure which we have to give, while rotating the hook or the needle, that we are exactly means we are not pushing too hard. I mean, we are just lifting incising the TM correctly. That pressure, any judgment, how will we get, or it is only through practice?
No, so actually it's not about the pressure. We don't need to apply the pressure. So hook, have you seen the hook?
Yes, sir. Yes.
I'm sorry. So have you seen the hook? So hook had the tapering end. Okay. So tapering end should go dip into the TM. So
Okay.
just like a sponge, you can think like a sponge. Like a sponge, we are scratching the sponge, but a sponge will be the little thick and hard. You can't scratch it.
Yes.
So you can understand like the butter. is the best example. Like the butter, you want to take out the thin strip of the butter. Similar way, what the TM you are seeing, the hook, just you go and just lift it, just lift and then just scratch it like that. The amount of pressure is required on the butter, the same amount of pressure is
Okay.
required on TM. No need to be too hard, no need to be too harsh, because TM is very friable, thin structure. So really we don't need any required of force. Once the TM is come in your hand, just you have to come gently. Move this way.
Okay. Okay. Thank you, sir.
Dr. Dipanjali ma'am has a question. Ma'am, you can go ahead and ask, ma'am.
Hello, sir. Good
Hi,
evening.
Deepanjali. Good evening.
Uh,
Be
it was
informal.
really nice.
You can ask any doubts, any questions, because when I learn really I learned from the talking the people, meeting the people. Even I learned from some of my junior colleagues also. So be informal. Don't think about it. This doubt, this is question is not worth. Every question is worth. Every doubt is worth. You can ask anything.
Okay, so like as you have told that we can use 26 gauge also
Yeah.
for the bang. So will there be any differences for making the angle in 25 or 26 gauge? Shall we make it little bit larger than the 25 gauge?
It doesn't require. Doesn't require. If you make the little larger, you're going to deep into the canal more.
Okay. So angle will be like similar in both.
Similar angle, make the 90 degree.
Okay. Thank you, sir.
Dr. Shivam, I also have a question.
Yes, Dr. Devendra sir will be answering, sir.
Sir, for a beginner like me, when we are entering through the entry wound, the phaco incision, the clear colon incision, how many clock hours we have to incise the TM in the first sitting?
So what
out
you
of 360 degrees, the TM is 360 degrees. How many degrees we have to? How many clock hours we have to incise?
So really, bang is recommended 2 to 3 clock hour only, not much actually. So do you want what single shot? How many time you have to ask, or you want total treatment area? What do you want to ask?
First time. Does it also depend upon the IOP? How much IOP the patient has and how much we have to incise?
Okay, I'm sorry, I'm not able to understand you. What do you mean by first time? When you're doing the first surgery?
Yeah, first surgery, first patient, first sitting for the patient.
So
how many clock hours we should aim?
Yeah. So I strongly recommend this. We can't. I don't believe we should do any try on our patients. So I will say before starting, follow the 20-20-20 rules. So first of all, be master during the 20 gonioscopy. 2 indirect gonioscopy you do. 20 angles you see first. Then next 20 cases, just you take that spatula, touch the TM, have the practice of touching the TM. If you have seen the 20 angles, you have touched the 20 angles, then the third step will be you can do the complete bang. No need to restrict your bang for your capability, because ultimately we are giving our patient is to you, patient come to you, so you have to give your best. So really at least what the recommended to the 2 clock hour on each side. Not because you are first time doing, you should restrict only 1 clock hour. No, that's not recommended. You can do it. You follow this now, you can do it. You can easily do it 2 clock hour on each side.
Okay, thank you, sir.
Yes, Dr. Vijay.
Yes.
Sir, we have to use the same port of the phaco, or we have to make some temporal port, because it will be difficult to push the patient, like making the position for the surgery. And secondly, sir, what will be the landmark for the goniotomy, because up over the TM or just above the TM, sir?
Okay, so sir, I want to know how do you do the phaco? Temple bone, temple ciliacorneal, or superior? Superior. If you're doing the phaco superior, really we need to make the one side port. Or sometime if you make the inferior side port, that also you can use for this doing the bang or Tanito. So your second question was how to. So really we not over. We going to the into the TM and then going to lift and cutting, sir. You if you above the TM, really you can't do it. So really we have to dip down the needle into the TM between the ATM and PTM junction. So first of all, sir, try to understand the structure actually. So I strongly recommend before taking your case for the surgery, do the gonioscopy with two mirror, especially assisting two mirror into the clinic. Understand the every structure. So select your first case. Somebody else was talking about the first case, Selindra. So first case means take the case where you can easily identifying the solvage line, ATM, PTM, skull spur, ciliary body. Select the first case. Your first case should be the structure where you can easily make out each and every structure. And that case you select, then go to the ATM, PTM junction, just lift the TM and slowly move forward.
Okay, got it, sir. Thank you so much, sir.
Welcome.
Hello, sir. Me again.
Hi.
Yeah. So, like, what should be the post-procedure medication, mandatory medication you have to give for like these cases? Because you have told that will be chances of hyphema.
So usually in the bang and Tanito, the hyphema rate are very, very less. Only thing you have to do, like we taught in our first practice, like we doing the SICS. What we learned the SICS. When we learned the SICS, beginner used to make the tight globe like a football. You understand that? Because we are afraid of our tunnel should not be leaked. So if you are performing the first bang or first Tanito or any other surgery, make your at the end of procedure, make your AC too tight, hard tight.
Okay.
So something you can do, you can tap your cornea with the finger. So if it should not depress. So that will give you the idea. If it is like that, so around your eye pressure around the 30 to 40 degree.
Okay.
40 mmHg, sorry, 30 to 40 mmHg.
Yes. Okay.
Okay. So make your hydrate your tunnel nicely, hydrate your side port nicely, make it tight globe. Then the chances of hyphema is very less. Then you are talking about the post-operative regimen. Post-operative regimen, what you're giving you for your cataract continue. In some of the cases, especially when dealing with the angle closure, I use the pilocarpine BD for that two times for 15 days, one time for next 15 days. This is my regimen.
Okay. So
But
any additional anti-glaucoma, sir? Any additional?
No, doesn't require. No anti. Stop all the anti-glaucoma medication.
Okay, sir. Okay. Thank you, sir.
So usually in how many weeks are we able to assess how much is the pressure exactly without AGM, and when is the need to, we already have a target IOP for a specific patient. So, but how long do we wait before starting the AGM?
Most of the patient next day, really it reduces in the next day to next day. But sometimes we don't know this steroid response is there in certain patients. That's the one issue. So when you want to start any MIGS case, the anti-glaucoma medication to reach the target IOP, stop the steroid first. First thing, stop the steroid first of all. Then look for the sometime for the IP spike. This is again most common. When IP spike means IP become 30. It quite happen in some of the cases within 1 month. Okay, so in such cases, when IP spike is there, give the short-term anti-glaucoma medication. Then once IP come down, stop it. Then you can continue. So we will see the effect within a week.
Okay, the final effect we are able to see within a week if the patient is not a steroid responder.
Yes.
And whether we do 2 clock hours, 4 clock hours, or 5, 6 clock hours, it doesn't make much of a difference in the results, sir?
This is a controversial topic. So at least but I do get a lot. So I strongly recommend the area of treatment really affect the IOP control. So, but it's saying if your treatment area more than 120 clock hour, is almost give the equal amount of the IP control when we look for the statics, look for the long term. Until unless you don't want the very good IP to control, we need 360-degree. Otherwise, 120-degree treatment angle area give the adequate result.
Because I remember I started with two clock hours to be on the safe side. For next patient, I started doing more and more. So now I'm able to cover around 120 degrees.
So that's why your question, you correctly point out. That's why I told him, Sailendra, don't restrict yourself for that because you are doing faster. Don't restrict yourself. You first make practice, then go for the 2 clock hour each side. It give you the adequate IP control.
Thank you.
Sir, hello. One more doubt.
Yes, please.
So if we don't want to combine it with cataract, like if the patient is phakic, still is it okay to go for MIGS? And if the patient is already pseudophakic, like the cataract surgery is already done, and later on, if we want to offer these surgeries, so what are the outcomes?
Yes, yeah, not only pseudophakic, you can perform in phakic eyes also, but I strongly recommend when you are learning, always do with combined surgery. That's the best way.
Yes.
And when you're talking about us doing MIGs in pseudophakics, really it works. But if you compare the outcome doing the MIGs in pseudophakic versus the combined MIGs with phaco, so result with MIGs with phaco is much better in compared to doing MIGs in pseudophakic eyes.
Okay.
Because after the phacoemulsification, some amount of force, some about the functional changes in the TM occurred, and really exact mechanism I really don't know. But this my personal experience when I doing the surgery in pseudophakic eye, my result is not that great when we combine with phacoemulsification.
Okay. Thank you, sir.
Hello, good evening, sir. Hello. Hello, Dr. Gaurav, sir. Good evening, sir.
Good evening, sir.
Good evening. Good evening. I'm so sorry. I'm in the shop I meeting. I just came out and from the session. And thank you so much for helping us conduct this program. And we are so lucky to have you with us on this session. And I'm sure everybody is going to learn so much. And I'm really looking forward to actually learning from all of you so many new things. So I hope the session is going well. And I didn't mean to disrupt it, but I hope session is going well.
Thank you so much for invitation, sir.
Please carry on. I'm just going to listen for some time.
Sure,
Carry on, sir.
Sure. Thank you, sir.
Yes, moving on to the next doubt. Dr. Ekta, I think so we interrupted you.
No, sir. The doubt was cleared. He answered it. Yeah.
Okay.
Thank you.
Dr. Smriti, any doubts, please?
No, sir, my doubts were covered actually.
Okay,
Thank you.
Good evening, sir. Good evening, Dr. Devendra. Sorry I joined late. I had one doubt. I don't know if this has already been asked before. But I just wanted to ask, what's your take on whether it's better to do the bang before doing the cataract surgery or after the cataract surgery? Since there's a school of thought which says that if we do it before the cataract surgery, the chances of a post-operative hyphema are lesser. Since by the time we're done, the bleeding usually stops. But at the same time, we are risking some, iatrogenic trauma to the capsule. Some people say it's better to do after the cataract surgery.
So your question is absolutely a fantastic question. So I will suggest when you're as a beginner, when you're doing the first time surgery, I strongly recommend do first cataract surgery, then you do the bang. Why? First of all, one thing, there's no don't have, we are doing the first surgery, first time IGS. So really we are always in some kind of pressure, how good we surgeon we are, but starting any new procedure, you have little bit worry about it. And really, once you do the BANG or KDB, whatever the procedure you do first before the cataract surgery, definitely there's some amount of blood reflex come from the surgery. So sometimes that blood reflex, again, you have to clean it. And I strongly recommend doing MIGS, use the blue. So you're using the blue, you're using some of the blood reflex, sometimes the blood and blue is going to mix you and making your phaco surgery more complicated. So I strongly believe as a beginner MIGS surgeon, always do phaco first, then stand again for your TM and then perform the any MIGS. And once you remove the lens, you are having the enough space to work onto the anterior chamber, and there is no chances of risk or chance or risk of damaging the anterior capsule. So you can freely move into the anterior chamber. So I strongly recommend do after the cataract surgery.
Okay, sir. Thank you so much.
Dr. Swati, any doubts from your side? I think so. Once more, you can tell how do we bend the needle for bangs, sir? Actually, many people must be having doubts, and can you just tell how to go ahead with bending the needle and any other takes on it first, sir?
No, it's just simple. What the needle you have, take the just tip. Just take the 1 mm tip only. Just when you're bending it, it should be the smooth, simple. They use the needle holder. Then use the needle holder and bend the just 90 degree. You have to bend it. Sometimes what mistakes beginners make, they make the too much needle actually. So just we have to take care. Just initial cutting part. Just that much you have to bend it. Not make the shaped bend. So most of the people make the bigger shape. When you make the bigger shape, that means your needle is going to be like this, much bigger. So when you enter, the high risk you enter into the canal. So that, and second, some people don't make the 90 degree perfectly. Really, we need to make the needle perfectly 90 degree because we are working on a curved surface. So if your needle is protruding or not the 90 degree, you are going to damage the adjacent tissue.
So for this also, with my experience, I can say I usually make 4 or 5 needles before OT, before starting the case. Then I choose which is the perfect one. Initial days I used to do that, and I used to go with and regarding one more doubt which was asked regarding the clock hours. So what I feel when you are going in extreme clock hours, even Dr. Mandeep will and other mixed surgeon will agree to me that initial surgery, initial your mixed surgery, you should go for initial 2 to 3 clock hours only, or 2 clock hours or either side. Don't go very periphery. Otherwise, you will go above or below. Am I right, sir, about it, sir?
Yeah, so really, my strong recommend when you are beginners, limit yourself 2 to 3 clock hour. But even the certain cases where you want to go beyond that, then you have to adjust the patient head and shift the lens. So patient head should be little bit downward and take your lens other way around. Instead of just nasally, go the infranasally. So basic principle of MIGS, don't touch or don't cut anything without saying. This is the principle of MIGS. So if you are reaching out, is not the problem. You can go reach up to 180 beyond 180 degree, but you should see, then you can do it. So if it is not visualized, strongly unrecommended. So what the people see, they just take the needle in the beyond, we are on right plane. Don't think in that way. You see, visualize it properly, then you can continue.
So any other doubts from anybody wants to share any doubts regarding the same thing? Dr. Ashish. Hello, I interrupted someone.
It's me only, Dr. Shivam.
Okay, sorry. Okay.
Sir, do you use pilocarpine intraop in all of your cases or none of your cases or as and when required?
So I use pilocarpine only in the PSEG cases or in the cases when my iris become very fluffy or because we encountered with all kind of cases. If it is not normal phaco case, I don't use pilocarpine in routine cases.
Thank you, sir.
And one more addition, in phakic eyes, when you're dealing with the phakic eyes, I strongly recommend we should use the pilocarpine to save our capsule.
We have not reached that stage where we will do it in a phakic eye, sir. I still prefer early cataract surgery along with MIGS rather
That's the
than
best.
doing just the MIGS
Yes, that's the best eye.
because it additionally offers another 2 to 3 millimeter mercury of pressure lowering. So,
Agree.
sir.
And one, I forget the name. Somebody is asking about the superior phaco and temporal MIGs. So really, sometimes you can use your side port what you make for the superior phaco, but I strongly recommend when you're shifting yourself completely temporally, so make the new fresh side port because we don't need the bigger side port. Single side port you make and temporal area, and you can perform the MIGs. That's much better in compared to, because we are working first time as a beginner, because our side port will be when doing superior will be little curved. So instead of working on the curved side port, make the straight temporal one side port and then do the surgery. And probably Shivam, Prasanna must have told you, zoom in and zoom out.
Sir, you can repeat, sir, please.
So I strongly recommend when we are starting the surgery, so any instrument is going into the eye, you should have to be zoom out the microscope. That should be a routine microscope setting, what you're doing on 0.6 or 0.5, whatever you're comfortable. Any instrument entering into the eye, any other BANG, KDB or microforceps, so zoom out yourself, see the tunnel, then enter it. Put the high density viscoelastic, then make the high magnification, then perform the surgery. So most of the beginners, and not only beginners, when we learn something new, we want to finish fast, we are always in hurry. So what we'll do, we are doing the surgery, we are not able to do, we have to inject the viscoelastic. Okay, we took the viscoelastic, after injecting the viscoelastic, we take the needle and the same high magnification. So if you're entering in the high magnification, you don't have the depth of perception. So what you're going to do, you're going to damage your tunnel. So again, basic, this is very small thing. Just zoom out yourself into your primary position, then enter into the needle, then again zoom in, then perform the surgery. I have one doubt. How many you have the Swan Jacob? Anybody have the Swan Jacob? You only.
So, sir, we are providing. That's the reason for our mix program, we have provided everybody. We are going to provide on-site lenses so that they can take back to their practice and start doing it. And the reason we have that WhatsApp group is so that everybody can ask their doubts and get it clarified. So, and that's why we are having a pre-orientation, like a pre-wet lab session, so that everybody has their all doubts clear before the actual physical thing. And we'll be providing everyone the gonio lenses so that they can go back and start practicing. And then they can upgrade to Swan Jacob one. So we are providing basic Katina lenses to them, which is almost similar to a Swan
Yeah.
Jacob.
It's good to start. I say Katina, both are the good lenses. You can start.
So I request Dr. Gaurav sir to conclude the session, sir. I think so. Nobody has many doubts. I think the sir left in between. Yeah, sir is still there.
He's in a conference, I guess.
He's a busy. So any other doubts from? Are we? Hope we have covered everything. Any doubts?
Sir has actually nicely covered everything, most of the things, and think all of us are looking forward to learn in practical now. I think attendance is a little thin today because still some people are in their OPDs.
Okay, right.
Yes, sir. So we all of them requested to have a recording ready so that they can view it later for anything they want to ask during the session.
Sure.
So we'll be share the recording. But it was really wonderful, sir. I am personally looking forward to meet you and learn from you. I'm okay with
Same
doing
here.
KDB. Bang, I'm still a bit scared of the needle, the sharp needle, it scares me. So KDB, I'm still comfortable because it has slightly elevated two edges.
No, I do agree. I do agree with the safety profile is much better in KDB, but again, the cost is that something we have
Cost,
to. So I strongly believe actually, if you get chance to do the Tanito, also try it. It is much easier than Bang and KDB. It's
is it
very
available,
easy.
sir? In India, is
Is
it
is a
available?
is it available? Jojo Surgical is selling actually. They duplicate copy, but it's not the actual Tanito. But somehow the our learning curve has been reduced for other MIGs.
Sir. So then we'll contact the Georgia one. I think we can definitely procure it and use it because it definitely is going to cut the cost.
Sure.
Thank you so much, sir. Thanks for a wonderful session.
Thank you. Thank you.
If we can reach maybe 10-20% of what you have achieved in glaucoma and MIGS, we'll be really lucky.
No, you all achieve more than me. I strongly believe.
Thank you so much,
Okay.
sir.
Okay. Thank you. Thank you so much. Thank you, Sam. Thank you all.
Thank you, sir.
Bye. Bye. Bye.
Thank you.